Welcome to this explainer. Look, as a clinical practitioner, you already know physical activity is great for the body. We all know that. But today, we're looking at exercise through a highly specific clinical lens as targeted brain medicine. We're going to break down the GETP 12 clinical guidelines to show you exactly how to prescribe FITT protocols, frequency, intensity, time, and type for 8 distinct neurologic, developmental, and mental health conditions. We aren't just talking about telling patients to take a casual walk in the park. We are talking about exercise explicitly supporting cognition, mood, and even neurogenesis.
Okay, let's dive into this. We've organized these conditions into 4 actionable buckets, starting with mental health, moving to neurodevelopmental and developmental, tackling neurodegenerative, and wrapping up with a rapid-fire final safety checklist. Pay close attention here, because while every condition has a base FITT protocol, each one also carries a really critical safety caution.
All right, Section 1, Mental Health. Here, we're zeroing in on the underlying mechanisms and specific exercise prescriptions for anxiety and depression. It's actually fascinating how completely different the FITT aerobic intensities are for anxiety compared to depression. They require entirely different clinical strategies. For anxiety, higher intensity is actually what you want. We're talking 60 to 90% of their heart rate max, supervised, actively progressing them from walking up to running. But for depression, the antidepressant effects hinge almost entirely on consistency, specifically programs lasting 13 days or more. The catch? Literally any intensity appears beneficial. So you've really got to meet your depressed patients exactly where they are on any given day, while actively pushing your anxious patients toward those higher supervised intensities. But with that higher intensity for anxiety comes a massive red flag. We call this the panic mimic. Think about it. When you prescribe moderate to vigorous exercise, it naturally elevates a person's heart rate and causes shortness of breath, right? Well, to a patient with panic disorder, these normal bodily sensations perfectly mimic a panic attack. If they misread these physical cues, they're going to be absolutely terrified, and I promise you, they won't come back. So your action step here is mandatory. You have to educate them beforehand about these physiological responses so they aren't frightened by them, and you must progress their intensity very gradually.
Shifting gears over to depression, your biggest clinical barrier isn't the physical capacity of your patient. It's just initiation and adherence. You have to remember that low motivation and low energy are literal symptoms of the illness itself. The clinical solution? Keep those early goals extremely small and really leverage supervised social support. Choose activities they'll actually want to maintain. And here's a really hopeful fact to share with your patients. Even a single isolated bout of exercise can provide an acute mood lift on a particularly bad day.
Let's see how this builds into our second bucket. Section 2, neurodevelopmental conditions, focusing specifically on pediatric populations dealing with ADHD and autism spectrum disorder.
So ADHD is strongly linked to differences in dopamine signaling. And what's amazing here is the mechanism. Physical activity naturally spikes both dopamine and norepinephrine. Guys, these are the exact same neurotransmitters that ADHD stimulant medications like methylphenidate target. In essence, exercise is acting as a natural complementary medication because even a quick 10 to 30-minute bout of moderate exercise improves attention shortly afterward. You should absolutely be advising parents to time this right before tasks that demand focus, like homework. Just be sure to coordinate with their provider on medication timing and keep an eye out for stimulant side effects like a higher resting heart rate. For autism spectrum disorder, your testing and prescription approach relies heavily on something called task analysis. You can't just shout out a broad global command. You have to break an exercise down into small, explicitly taught steps before you ever expect the patient to perform it. And notice step 2 here. You really want to lean toward individual activities like swimming, cycling, or skiing. Socially demanding group activities can just provoke unnecessary anxiety. Finally, you've got to engineer the environment for success. Maintain a highly predictable structured routine, use plenty of visual cues, and strictly manage any harsh sensory inputs like bright lights or loud noises.
Moving right along to Section 3, our developmental bucket, here we'll look at the specific protocols for Down syndrome, intellectual disabilities, and cerebral palsy. For patients with Down syndrome and intellectual disabilities, your exercise prescription comes with some very strict cautions. First off, always screen for congenital heart defects. They're quite common in this population. But the crucial must-know caution here is atlantoaxial instability. This is a laxity in the upper neck ligaments. You have to actively avoid any activities involving forceful neck flexion, think diving or certain gymnastics, unless they are completely medically cleared. On top of that, people with Down syndrome often have a blunted heart rate response, meaning their peak heart rate is actually lower. If you try to push their intensity using a standard heart rate monitor, you're going to overwork them. You have to use the rating of perceived exertion, or RPE, instead. For cerebral palsy, we're dealing with permanent movement and posture disorders caused by a non-progressive injury to the developing brain. It causes spasticity, weakness, and impaired balance. Your absolute guiding star here is the GMFCS, or Gross Motor Function Classification System. This 5-level scale completely dictates your choice of testing and adaptive equipment. For instance, treadmill testing might be perfectly fine for higher functioning ambulatory individuals at levels I and II, but you'll absolutely need to pivot to arm ergometry or the submaximal 6-minute walk test for others. Now, because patients with cerebral palsy suffer from low weight bearing and generally reduced mobility, their risk for osteoporosis and bone fractures is significantly higher. So your FITT protocol absolutely must emphasize progressive resistance loading. Why? Well, not only does it improve their strength and day-to-day walking function, but weight-bearing resistance is critical for actively defending their bone health and preventing devastating falls down the line. That brings us to Section 4, neurodegenerative conditions. Now we're shifting our focus to aging populations dealing with Alzheimer's and Parkinson's disease. We know Alzheimer's is progressive and irreversible. And while exercise certainly doesn't cure the disease, it is absolutely vital for maintaining function, mood, and independence. The FITT protocol calls for aerobic exercise 3 days a week, but your intensity is dictated entirely by the severity of the disease. You start light and gradually progress to moderate. But here is the big pivot. Their cognitive impairment has to shape everything you do. You must use simple, repeated, and familiar instructions. Keep their routine and environment incredibly consistent. And most importantly, you have to ensure direct supervision, often involving caregivers, because wandering off and getting lost are major safety hazards. Parkinson's disease involves the loss of dopamine-producing brain cells, which leads to those classic motor signs: tremor, rigidity, bradykinesia, which is just slowness of movement, and postural instability. Severity is staged by the Hone and Yahr, or HY scale, and this brilliantly illustrates your clinical objective. Because the disease inherently makes a patient's movement small and rigid, your exercise prescription has to push the opposite. You need to emphasize large amplitude, deliberate movements alongside dedicated posture and balance work. But with Parkinson's, timing is quite literally everything. Their symptoms fluctuate drastically based on their medication dosing, creating what we call on and off periods. Let's trace this timeline. At time 0, they take their levodopa medication. You need to wait roughly 1 hour for that medication to fully absorb. That kicks off the on period, which is when their mobility is at its absolute best. You must schedule your exercise sessions during this specific window, because it is by far the safest time for the patient to be up and moving. You also have to manage 2 massive fall risks with Parkinson's. First is the dual task caution. People with Parkinson's really struggle to split their attention. If you have them dual tasking while walking, their fall risk skyrockets. So especially with novices, use simple, single-focus cues, whether verbal, visual, or tactile. The second massive risk, orthostatic hypotension. This is a sudden blood pressure drop upon standing, and it's actually both a feature of the disease itself and a side effect of levodopa. To combat this, just make sure they rise slowly and significantly extend your cool-down periods. All right, we've covered a lot of ground today. Let's move to our final section and bring all of these isolated FITT protocols and isolated cautions into one rapid-fire clinical summary, the final safety checklist. If you take absolutely nothing else away from this explainer, memorize this anchor slide. Let's run through it. For anxiety, push that intensity, but proactively watch for the panic mimic. Depression, any activity counts, just prioritize getting them to adhere to it. For ADHD, leverage that natural dopamine boost with a quick workout right before homework. Autism, use task analysis and highly predictable structures. Down syndrome, never forget atlantoaxial instability and always use RPE because of that blunted heart rate. Cerebral palsy, match your equipment to their GMFCS level and aggressively combat that osteoporosis risk. Alzheimer's, keep routines incredibly simple and always supervise for wandering. And finally, Parkinson's, only exercise during that medication on time and avoid dual tasking to prevent falls. We know beyond a shadow of a doubt that exercise supports brain health across all of these mental, neurodevelopmental, and neurodegenerative conditions. It truly is powerful natural medicine. But like any medicine, its efficacy relies entirely on the precision of the practitioner. The FITT protocols are right there. The safety checklists are clear. So the only question left is, are you dosing it correctly for your patients? Challenge yourself to apply these exact protocols in your clinical practice tomorrow. Thank you so much for joining me for this explainer, and keep learning.